This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. How do we deal with a posterior capsular plaque? Let's find out in this case. She's an elderly lady who has this mature white cataract, and she's posted for cataract surgery, and let's see how things turn out. The surgery is being done under posterior subcutaneous anesthesia. The two side ports are made, the anticapsule is stained, dispersive OVD is placed into the bag. The globe is stabilized with my second instrument, which happens to be an aspiration cannula in this case, and a 2.8mm posterior limbal base triplanar incision is created. Time to perform the rhexis. I'm aiming a rhexis about 4.5 to 5mm centered on the central Hirschsprung reflex. The rhexis is done. It looks to be decent sized and well centered, and time to emulsify the nucleus. The overlying epinucleus cortex is then first aspirated. Now is the time to divide the nucleus. I'm going to use the direct chop technique. The tip is buried into the substance of the nucleus. The chopper goes down vertically, and then there is lateral separation maneuver. The first crack is achieved. The nucleus is rotated, and similarly the nucleus is divided using the vertical chop technique into 6 smaller pieces. And each of these fragments then emulsified in a controlled manner at the level of the capsular axis. Long-standing cataracts usually have a problem that the posterior capsule will not be very clean, so remaining cortex is aspirated out, but we see a lot of muck sticking onto the posterior capsule, and one such plaque is directly in the visual axis. I'm just trying to polish it with my BSS. It's not going to budge. So this got me thinking, should I intervene with it now or should I leave it for later, do an YAG? So I thought I'll first place the lens and then take a call. The OVD is placed into the bag. The IOL is gently maneuvered into the antechamber and then into the bag. So now we have the lens sitting nicely in the bag, well centered. I'm going with my Sinskuk and trying to scrape off this plaque, but it's unlikely to budge. So this time I take a call that let me try removing it with a forceps. But when I'm attempting this, there's always a risk of rupturing the posterior capsule, and I may have to perform a PCC, and in turn, if the antihyaloid is ruptured, I may have to do an antivitrectomy as well. So I thought let me try, and I'm using a microforceps through the side port, and I'm just holding at this elevated plaque and trying to cling at it and peel it. And with some difficulty, I could peel it off and create a small circle. So we have a central open area. At this point, I don't think the posterior capsule is ruptured. This is just the plaque which has come off. And I need not worry about, causing a vitreous disturbance. So the OVD behind the lens also is washed off using the irrigation, and as well as the OVD which is in front of the lens. So with the OVD removed, the lens looks to be very well centered and a good clean visual axis. The side ports are iterated, and that's it, the case is done. These are the post-op pictures, and the patient had a very good visual outcome. Well, to summarize, in such situations where there is a plaque in the visual axis, it's perfectly fine to just leave it and YAG it later, but one can also attempt to remove the plaque. But mind you, in that process, there's always a risk of damaging the posterior capsule. But even if the PC is torn, we can always do a PCC, and it should be reasonably safe. But in the worst case scenario, if there is a vitreous disturbance, then we should be ready to perform the vitrectomy as well. So these were a few thoughts for this case, and that's it. Thank you for watching, and hope you found this helpful.